A very good evening to Sir and everyone. A warm welcome to Sir Dr. A. Srinivas Murthy to this interview
Yes,
session. It's my great
yes,
honor and privilege to invite Sir in this session. And I'm
yeah,
Dr. Kajuri Giri, passed out nephrologist, recently from Osmania Medical College and Hospital, Hyderabad. Dr.
okay,
Murthy is a nephrologist par excellence. He has garnered great clinical experience in India and abroad. He is also is very passionate for towards academics, and he has trained scores of students in nephrology training. We are
yes,
privileged and honored to invite Sir for this ISN Con to be held in Hyderabad for the Dr. JCM Shastri Symposium to be held on 9th of February. A warm welcome, Sir. First question to you will be I would like to know, sir, your background in nephrology and what are your main areas of expertise?
yes. Yeah, thank you for contacting me. And thank you, your organizers, and Dr. Manjusha and Dr. Gangadhar. They are my colleagues. They were my colleagues, rather, way back in Hyderabad 20 years ago. So, when I worked in your own Usmania as assistant professor of nephrology, 2006, I think.
Okay, sir.
So, yeah, that is how I started. Actually, my nephrology career started way back as 2002 itself, as a assistant professor of medicine when I started dialysis in my medical college, Rangara Medical College, in my place. Then that is how I got sucked into the stream of nephrology. Then, of course, I did my DM and then later came to Usmania as teacher. And then later I was working. Initially, I was under Dr. Girish sir, Girish Narayan sir. That was my initial entry into nephrology. Later on, I've been moving around across so many corporate hospitals in Hyderabad, doing extensive clinical work, and my main area of focus was transplantation, and both live and cadaver transplantations in various corporates in Hyderabad. And also, I was one of the first few people who started HDF, both as an OPD and ICU. First, myself with my colleague Kamal Kiran, we were one of the
Yes, sir.
first people to start HDF in Hyderabad, not only as an OPD but also in the ICU in place of CRRT as a hybrid therapy. That was my work mostly for almost 15 years in Hyderabad. Later, I moved to Kenya for so many reasons, partly financial, partly other logistics. Development in new areas, not because I've been moving across not one corporate, so many other corporates. So the Kenyan counterpart was also an Indian hospital where they contacted me. It was an Indian, owned by Indian gynecologist couple, Dr. Swaroop Ranjan Mishra and Dr. Pallavi. Both are postgraduate gynecologists from Orissa and various places. They have their own hospital of nearly 20 years standing, and they wanted to start the transplant program. So that was one of the reasons they contacted me. And then I had to come to Kenya. And then the challenges were very really tough for me, because for the first time in Africa, first thing. Second, though it is an Indian hospital, the nephrology services were almost primitive, and even dialysis they were not able to do properly. It was, though funded by the government, it's only twice a week. And then ICU dialysis, they have very poor concept. They don't know, many
Yes,
hospitals don't know CRRT. And
yes,
but it's a few centers were still doing. Somehow they started doing HDF even at the time. I'm surprised to see HDF in a government medical college.
yes,
So that with the background of that, then my first task was to upgrade nephrology, do the proper vascular access procedures, teach them, and then I made ultrasound guided mandatory, and then CAM guided catheter placements, because I do it regularly under CAM and ultrasound guided. So it took me nearly 6 months to get the licenses, the difficulties of the initial, and then we started the transplant program. And the surgeon used to come from Hyderabad. He is my friend there.
Yes.
So they used to come, and then that's how we started the program basically. So it's
Okay, sir.
initially it was around 3 or 4 transplants per month, because I used to work up the patients, and then I never have any lab facilities except the basics. The other facilities like cross matches, I have to depend on Indian labs. So I have to mail my cross matches, these blood samples to India labs, and then get the reports, and then keep patients ready, and then get the immunosuppression from India, the induction thymoglobulin, and other immunosuppressants, everything I have to get from India. And then that's how I started the program, and slowly it started picking up. So and Kenya transplants were happening, but later, slowly, after 6 months, I realized they were not up to date in their methodology and the protocol wise. Somehow I was not happy. Even the protocols which I was doing in India in various corporates, I myself started being a little uncomfortable with them. The way, like even in India, apart from the that CDC was the only the cross match we used to do, and later I switched over to DSA levels. Then I was doing initially DSA levels here. Then even that somehow I was not happy about the flow cytometry, and I was discussing. I was in regular discussion with the transplant immunologist across the country.
Okay, sir.
Then somehow I got I don't know why I made the decision to go to NGS technology and SAB analysis for every patient. So
Okay, sir.
every transplant I took up, instead of going through CDC, flow cytometry, DSA levels, I got fed up, and then I started doing for every patient mandatory NGS, all the 6 into 2, 12 alleles, and the single antigen PED analysis. I made it mandatory for every patient, and I used to do the virtual cross match myself. They provide the
Okay,
MFI
sir.
levels, and then I do the virtual cross match myself. That is how I started. And then surprisingly, I started noticing one thing I noticed was, because it is Africa, and access to immunosuppression is very difficult for me. And if the kidney rejects, there ends the story. People cannot afford thymocyte for a rejection. Even to give for induction, I have to be very stingy about the dosings, because I cannot have
Okay,
all
sir.
the. There is no overnight availability of trans immunosuppressants for me. So I started doing all positive DSAs and positive SAB virtual cross matches, plasmapheresis. So I used to do plasmapheresis and then give IVIG, then desensitize them. So I never allowed even a single few MFI values to be higher, because I cannot afford a rejection in Africa. And neither only I cannot afford, patients cannot afford, hospitals cannot afford. So that what happened was, I started gaining more and more insight into SAP technology, and I started getting more and more confident of doing the virtual cross matches. And though initial idea of doing SAB was to avoid unnecessary plasma for a non-specific DSA, but later when I noticed nearly 70%, I think, if I am correct, mild to moderate sensitization of all the patients, because all our fistula is very rare in India, Africa, and most are on tunneled catheters for 1 year, 2 year, 3 year, and then EPO is hardly available in the adequate doses, recurrent blood transfusions. So the DSA levels were high for every patient. So
Okay, sir.
then I started doing plasmapheresis, and the results started getting better and better. Almost it reached 95 plus percentage, even in the first 6 months of my data.
Okay, sir.
So I developed
Okay,
my
sir.
own software, like the no dedicated software for nephrology or dialysis or transplant in Africa. I developed my own protocols, Excel-based sheet, Word sheets. So all the patient data I started capturing myself sitting alone. So I have nearly a data of nearly around 380 patients as follow-up captured in Excel sheets and various protocols which I developed. So this is my journey,
Yes.
and then the numbers started building up as the results started increasing, getting better and better. Now I get a clientele of around nearly 10 to 15 countries coming to Kenya just for kidney transplantation. So this is my
Yes.
journey. And
Yes,
the
sir.
second part of it was there are many new areas which I started unearthing with the first time where in India, even for 15 years, I did not do. Like I started recognizing HDF is a golden methodology for treating uremic cardiomyopathy. And the commonest complication of CKD, I found, though it may be in literature, but not much, PAH is the main troublesome, which many patients were precluded if the PAH goes beyond 40s or 50s. They were disqualified. And so these areas where, when I put them on HDF, there is a miracle. The EF improves, PAH comes down, they eat well, they do well, and then they become very easily fit for transplant. This is another finding which I found out. Another finding which I found out, which was not even practiced in India, is people look at only GFR as an indication for starting dialysis. I have done so many preemptive transplants from so many countries. They were just waiting with a GFR of 15 ml, 20 ml, and then waiting to get transplanted. But when I look at their PAH, everybody moderate to severe PAH. At least in our traditional teaching in nephrology, we were not told to link up falling GFR with PAH levels. This is what I noticed in my practice over 5.5 years. Then, before taking for even a preemptive transplant, I put them on HDF, bring the PAH down. Then only I take them for transplant. Otherwise, there are a few cases of irreversible PAH which we did under epidural anesthesia. Transplants under
Okay.
epidural anesthesia. This is also the third new thing which I have started in these parts of the country. And many other highly complicated cases we have done, like other than multiple arteries and aneurysms and dissections of the aorta. I have developed new radiology protocols here called the CT trunk protocol. So, and I have a lot of data on that, and also a lot of data on parathyroidectomies. I have done at least 8 or 9 simultaneous parathyroidectomy and transplant together. The same table, the
Okay.
same day, with intra-op PTH monitoring. So these are one of the innovations which at least I was not doing in India. Now I started doing. I think it started going like a wildfire across the countries, and then people started recruiting in. Now I think by December I did around 380 plus transplants.
Yes. Sir, a
Okay,
great achievement
so this is my
indeed, and we
journey
can understand.
across. This is my journey
Yes, sir.
across 5 years in Kenya in a resource limited setting, which I presented in
Yes.
Bangkok last year
Yes.
in the
Yes, sir. We can
WCN.
understand that the courage and the hard work should have been gone after this.
Yes,
Sir, coming now to
and all this single
ISNSC.
man.
Oh,
Yes,
great,
please.
sir. Yes. Yes, sir. Now, my next question, taking forward to the conference, sir. What is your
Yes,
focus of your presentation as ISNSC Con 2024, and why do you think it is significant for the nephrology community, sir?
I am just trying to share colleagues in ISNC Hyderabad Southern chapter that how I had to upgrade myself to higher technology even in a remote place and get international results with international clientele, where even as basic as, am I going to look into the area where we have to dialyze patients earlier, not for GFR sake, rather for a cardiomyopathy? That is one question I really want to address, because I am a single man in a single center private setup. Difficult for me to have a properly data of these things. And also, I mean, because at that point, the HDF was not extensive at the time when I left 5 years ago. It was not common. Second, Both NGS and SAP technologies were not practiced in most of the centers. Most of the nephrologists were limiting themselves to CDCs, DSA only a few centers. That was the background from which I started my journey in Africa. So I just want to tell that even a resource limited setting like a third world country, where people used to are traveling from African countries to India or other countries for transplant. Now, after I came, literally it has stopped completely. Almost it has become very, very less people leaving for other countries. I mean, this is what I have to give the third world countries as a gift, at least. Yeah, I think so. I may not be able to teach Indians, but at least these part of the people where I have started this technology, people are very much happy. All the nephrologists are very happy. It is because they are not much exposed to the higher end version of cross matching, HDF, and the fine tuning in transplant. I have seen not very much, because now that I have a very huge volume of data, which I entered myself, I'm able to fine tune my tacrolimus dosing, MMF dosing, very fine tuning. I could get hands on, which I never had in India. Even in India, I could not have that fine tuning. I don't know, but this is where. So I just want to highlight the journey of even in a moderate setting and a rather actually limited setting, where a high-end nephrology practice can be delivered.
Yes. Sir,
That
in
was one going to
continuation
be
with
my.
this, yes, sir. So, in
Yes, please go
continuation
ahead.
with this only, my next question,
Yes.
sir, will be how important do you feel that international collaboration is in advancing medical research and nephrology training and research and patient care? And you have been doing this international collaboration since long. So, how do you
No,
think that
actually, it is
it
not. See, it is
benefits?
a private setup. It's a private setup. Collaborations are not very important. All my practice is based on actually word of mouth. Strictly it is word of mouth, and my presentations in other African countries, I approached many local country kidney foundations. Like for example, I was speaking in Uganda last year. So the nephrologist community are still struggling to provide ordinary dialysis. The countries around Africa is a resource limited setting all over. So they are struggling even to provide a conventional twice, not even conventional, I mean limited dialysis per week. And many programs are not government funded. Many programs the patients has to pay. So from I get patients from other African countries, I get them in a very poor shape. So it is it's a very upstream task for me to optimize the dialysis first, bring down the systemic complications, bring up his hemoglobin, bring up his EF and PAH properly. I mean, treat the bone disease. Most of them don't even know PTH monitoring and how to treat high PTH levels more than 1,000, and how to do a scanning for a parathyroid. Nuclear scan is very limitedly available. I do system-level scanning for parathyroids before I take them for surgery. I mean, these are the innovations I did in a third world country. I think that's where maybe India may not be at that stage, because that's where I have learned all these things. But these people, I think, these countries, these people, they definitely needed my. And even European countries, I have patients from US, UK, and many Middle East countries. I went through their transplant protocols. They come with their cross-match reports. They come with their cardiac reports. It's very rare to see that a cardiologist looks at the heart. I don't know that we are stuck with GFR. I think it's time. Even in India, I was not looking at the heart in a dialysis patient unless some outright cardiovascular event is there. Now that when I'm doing in bulk, now I should see that look at the heart. The moment a CKD stage 4 comes to me or stage 3 comes to me, I get a 2D echo baseline done. So as the patient comes for my follow-up on their stages of CKD across various levels of falling GFR, now I will mandatorily get a 2D echo, and all my team members have trained them. Even my marketers, they first ask the patient, what is your 2D echo? Where is the pH? Even my marketer knows less than 40, more than 40, Murthy sir is not taking you. I
Yes,
mean,
sir.
these are the
Yes, sir.
innovations, and I like to, which happened in, I had to face, and that's how I came up with the solutions.
Yes. To concluding, sir, what are you most looking forward towards ICNSCON in Hyderabad, sir?
I just want to encourage young, see, imagine a man of my age working alone, trying to fight and get one young girl or boy like you to assist me. They're afraid of Africa. What? Africa? Oh, full of jungles, animals, apes, monkeys. There are people here. It is flooded by Indians. This is no longer Africa. It is, I'm living in an Indian community. I'm living with Indians. It is an Indian hospital. All the top guys are Indians here. I don't miss even idli and sambar here. So I've failed to get, just imagine a man of my age failed to get a younger boys and girls of your generation to assist me, because I want to take this bias out of the Indians that Africa is a condemned land. No, it's a growing land. People are intelligent. I could train my African boys and girls as equally as my Indian boys and girls.
Yes,
Okay.
sir. It's truly a global village. Yeah. Yes, sir.
Yes,
And
yes.
lastly, sir, do you have any
Yes.
message for the delegates for this conference, sir?
Not much message, but even in see, what setup you are in is not very important. Like me, I faced the poorest of the poorest countries and also very limited settings, and I could deliver an international transplant program not through any collaboration. It is pure word of mouth. Unless I did 200 transplants, I never got one single international patient. It is after 200 transplants, people started recognizing my work. Then, see, if a simple word of mouth can do this much, but collaborations from a government level or at other levels, third world countries will be very easily benefited. Even many parts of the India are still like third world countries. I worked in villages in India. I'm not a Hyderabadi guy. I come from even more remote places from Andhra. So I know, because I am the fellow who started dialysis in my college as a teacher in medicine till I got my MD in 93. Now I started dialysis 10 years later in the same medical college. Just imagine the pathetic state of nephrology at the time when I came out. So even in resource limited status, we can deliver high-end technology and high-end services. That should be my message for the boys and young generation of your age and generation. Okay? Need not be biased. Need not be biased. Need not stick to corporate hospitals in Hyderabad. That's it.
Yes, sir. It was a great interview and a great chat with you, sir. It's my honor and pleasure. And we look
Yes.
forward to welcome you and host you in Hyderabad in February, sir. And hopefully
Yes,
we'll
yes.
have a great time. So we'd
Yes,
like to
yes.
conclude this session. Thank you so much for your time and
Okay, thank you.
patience, sir.